First of all, I'd like to start by just giving a round of applause for our fantastic speakers this morning. Those have been some really inspiring talks, so thank you so much, everyone. All right, thank you all for choosing this room for the people, experienced people with Parkinson's disease. I call it the big kids table, so I'm glad you're here with me this morning. I'm looking forward to speaking to you about some new updates on new medications and pump therapies for people with Parkinson's disease. I'm Amanda Currie. I'm one of the second-year Movement Disorder Fellows here at the University of Florida, and I feel very fortunate to be able to learn here from these fantastic teachers and from all of you patients, caregivers, spouses. I feel very fortunate, so thank you. All right, so without further ado, let's get started here. First of all, I don't have any conflicts of interest to disclose, but I do want to thank the Davis-Rembert Family Foundation for funding my fellowship. Here's a little outline of things that we'll be covering this morning. First, I'd like to start with just talking about our current drug therapies and what the current landscape looks like. Then we'll move on to a newly approved drug that hit the market in the last year. Next, we'll talk about the pump therapies that are available right now, and then one that's coming soon. We'll talk about other new drug therapies that are kind of on the horizon, things we can expect in the next few years. And finally, we'll touch on a couple of topics that have been a lot in the news in the last year or so to kind of go a little bit more in depth about those. So kind of setting the stage for some of the things that we'll be talking about. When we think about treatment of Parkinson's, it's all about the dopamine. So the primary problem with Parkinson, as we've heard from several of our speakers this morning, is that the brain doesn't make enough dopamine because of death of the cells in the brain that make the dopamine in the substantia nigra. So as you can see, there's dopamine that's involved in several different systems within the brain, and some of them will make sense when you think about some of the symptoms that you or your loved ones might have with Parkinson's. So in the red, we see the movement-related symptoms, where dopamine is involved with voluntary movement production. And then you also see other symptoms that are involved, things like thinking, memory, learning, motivation, different emotions, and reward processing. All of those are affected by dopamine. And so you can see how adding back dopamine can help restore some of these symptoms back to more normal levels. So just kind of looking briefly at a history of Parkinson's treatments and history in the last couple of 100 years, you can see that Parkinson's disease was systematically described back in 1817, and then it wasn't until the 1950s or so that we started to get some treatments in the form of surgical therapies. And then we got our first FDA-approved, or one of the most effective FDA-approved drug therapies for Parkinson's disease in 1970 with the approval of levodopa. And many of you will recognize that because it's the active ingredient in carbidopa-levodopa, one of the medications that most people with Parkinson's will take at some point in their journey with Parkinson's. Then in the 90s, deep brain stimulation came on the scene and was approved by the FDA. We had approval of pump therapy in the form of Duopa in 2015, more recent approval of focused ultrasound therapy, and here we are in 2025. Dr. Burke will be covering some of the things there at the bottom of the slide, but we'll focus more on the top part in my talk today. So just kind of reviewing some of the things that a person with Parkinson might describe and might experience with regard to their medications throughout the course of Parkinson's disease. To orient you to these graphs that you'll be seeing in the next couple of slides, on the bottom are the time during the day, and then on the vertical axis you see the dopamine level in the bloodstream. The shaded blue area is kind of our therapeutic window, the place where we want those dopamine levels to really stay for the majority of the day. I kind of call it like the Goldilocks area, sort of. You don't want it to be too high, you don't want it to be too low, you want it to be just right. What happens if you get outside of that? On the top side, you'll get the high dopamine side effects that you all might have experienced. Things like dyskinesias, those extra involuntary movements. Could be things like hallucinations or orthostatic hypotension. So those are things that we would like to avoid if we can. And then on the other end of the spectrum, down at the bottom of the window, you'll see some red areas, and those are kind of the off symptoms. So almost as if you're not taking those medicines. You're seeing your Parkinson's symptoms returning, the stiffness, the slowness, the tremors, and the feeling like you just need more of that dopamine. So here in the early stages, you get pretty good continuous benefit from your carbidopa, levodopa. You don't get many of those fluctuations or the highs and the lows, and you're going along pretty well with just taking your medicines a few times per day. Moving on to kind of the middle stages, after people have been living with Parkinson for a little bit longer, you can see we're starting to get some of those fluctuations, or we're getting out of that Goldilocks period. We're getting some of those dyskinesias up at the top. We're getting some of those off periods down at the bottom. And then as Parkinson advances, you'll see people often have to take their medications more frequently, and they spend more of their day in either the high or the low area outside of that ideal therapeutic window. One more thing I'll highlight on these slides is the term that the trials like to use, that I'll be referring to as we go along, for that blue shaded area is good on time. Okay, so if we think about how we can best manage the symptoms for people with Parkinson's disease and maybe manage some of these fluctuations, we've got several different approaches that we can think of, and most of them make a lot of sense. So number one is you can just increase the dose of levodopa if you're just not getting up into that shaded blue area. You can also increase the frequency, so take it more times during the day. You can also try different controlled release formulations. Some of you might have tried this in the form of Sinemet controlled release or Sinemet CR. We also have Rytary that's an option that uses this mechanism too. It lasts a little bit longer. Another option that we have is to prevent the breakdown of levodopa before it gets to the action where it can do its benefit. A couple different medication classes use this mechanism. One of them are the MAO inhibitors, so things like selegiline, rasagiline, or things like Azilect that you might have been familiar with. And then the other one is COMT inhibitors in this enzyme preventing breakdown category. And those are things like entacapone, or tocopone, or opicapone. Next, we have an approach to treating Parkinson's symptoms that involves stimulating the dopamine receptors without increasing dopamine itself. And so that class of medications is called dopamine agonists. And so those are medications that you might have heard of or tried, things like ropinirole, pramipexole, Nupro, or rotigotine, and one that we'll talk about a little bit later on called apomorphine. Finally, you can think about continuous drug delivery devices and strategies to help kind of smooth out that delivery of the doses throughout the day. And things that use that mechanism are things like pump therapies or transdermal patches that deliver the drug more evenly during the day. So you might ask, we've known about Parkinson's since the 1800s. Why don't we have more treatments that are available for people to try? Well, a lot of that comes down to it just takes a lot of time for drugs to move through this approval process. On average, it takes somewhere around 10 years or so to go through from the preclinical or the animal and cell-based models into the when it hits the market, when it's available for us to use in routine clinical care. And then kind of the earlier phases focus on making sure that the drug is safe for people to take, and then establishing, does it really treat the symptoms? Does it do what we want it to do? Once they have that data for enough people, usually in the range of hundreds to even thousands of people, they can accumulate that data, present it to the FDA, and the FDA can say, yes, we approve it for use in routine clinical care, or no, we need some more information, come back and try again later. Throughout the presentation, at least for the new therapies, I'll be focusing on medications that are in the phase 3 clinical trial range that are most likely to come to the market soonest, just to kind of focus our discussion a little bit. And those trials will be denoted by this black circle 3. So that'll be the key that I'll use throughout the presentation. Okay, so you might think, how do we measure Parkinson's symptoms in these trials? What are some endpoints that we use? And they fall, at least in these trials that we'll be talking about, into 2 big categories. One are rating scales. So those rating scales can be things that your doctor observes based on an office visit. So a lot of you are familiar with the examinations that doctors do every time, or the movement specialists do every time you come into the office, this sort of thing, this, checking your tone, all of that. So that's part of a rating scale that doctors observe. And then there's also patient-reported rating scales, things where you rate how your symptoms are doing. So how are you doing with bathing? How are you doing with brushing your teeth? How are you doing with speaking, with choking? That sort of thing. And then the other category that we think about are how well and how long do you think your medicines are working? So how long do we think that you're staying in that Goldilocks period, the blue period that we talked about before? And there's 2 kind of measures of that are used in the trials. One is how much good on time are you having? And so that's the area in that blue bar. And then the other metric that's often used is how much off time are you using, or how much off time are you having? How much of the red below the therapeutic window are you spending? Okay, so now that we've kind of set the stage, I'll turn and talk about the newly approved drug that's hit the market in the last year. That drug is called Crexont. It is a new formulation of carbidopa-levodopa. And what that is, it's a capsule that contains beads. One of them is a slow release, and then one of them is immediate release. So it is designed to kind of give you more continuous effect of the medication throughout the course of the day, without having as much of those highs and lows, and without having to take it as frequently. It was approved just last August of 2024. And we'll look at some of the data that led to its approval so that you can kind of learn about what we're analyzing when we think about these trials. So basically, they found that the amount of good on time per day in that Goldilocks period was 0.7 hours compared to optimal oral therapy with Sinemet. And conversely, the amount of off time per day improved by 0.6 hours compared to Sinemet. And then one important thing to note here is that the people who got the active drug, the Crexont drug, only had to take their medications 3 times per day compared to the people in the carbidopa-levodopa or Sinemet group who took them 5 times a day. So even that in and of itself is really helpful for a lot of people because that schedule is a lot easier to keep up with compared to having to take the meds so frequently. With all of these different treatments, it's important to think about what side effects are we having? What would we potentially be giving up with a therapy like this? Or what would you have to deal with that's new? And those side effects in the Crexont trial were pretty infrequent, all in less than 5% of the people, and included nausea, anxiety, and dyskinesias, really symptoms that can happen with most of the levodopa-based therapies that we see in use today. So you might ask, this is great that we have this new medication on the market. It's exciting. It's exciting to have to take it fewer times per day. Who might be a candidate for this therapy? And what's been our experience with getting this therapy to patients? Since it's new, it's more expensive, and insurance companies are not as eager to cover it. So in my experience, it's usually a good option for people who have tried things like the immediate release carbidopa-levodopa and maybe a couple of other medications and just aren't having the responses that we would like to see. And so this is kind of something that we try later on in that progression of things that we try for Parkinson's disease. Okay, next we'll turn to some of the pump therapies that we have for people with Parkinson. And again, I'll kind of touch on when I would expect to use these sorts of therapies for people with Parkinson. Usually it's in people who have had, again, good trials of oral medications, and they're just not working for people. They're having to take their medicines too frequently, they're having too many side effects, too much dyskinesias, too much off time, or they just can't tolerate the levodopa for whatever reason. Could be that they have a lot of nausea when they take their oral carbidopa-levodopa. Or that it's just not working. They might have some gastroparesis or some GI concerns that make medication delivery through the mouth just not a good option. So those are the kinds of people that I'm thinking about could be candidates for these sorts of therapies. The first pump-based therapy we'll talk about is Duopa. As I mentioned, this one came on the market back in 2015, so we have a pretty good track record of using this, and we have a lot of people in our clinic who we still treat with Duopa pumps. And the way that this drug works, it's just a continuous infusion of carbidopa-levodopa into the small intestine. So the idea is, again, you give it throughout the day and avoid those highs and lows and just kind of stay steady throughout the day. One thing to think about practically for this therapy is that it does require a surgery to place the tube that is used to deliver the medication. But that's a one-time surgery, and then the tube kind of stays there throughout and delivers the medication. Here's a little schematic of what it kind of looks like. So you see the tube that goes down into the small intestine and then is connected to a device outside the body. That bottom part is the cartridge that stores the medication, and then the top part is the way that you interact with the pump and that we program it and that you can give an extra dose if you need to. Looking at the phase 3 trials that have studied this before, it led to pretty good improvement in off time per day by 1.9 hours compared to the regular oral Sinemet. And then similarly, the good on time per day really improved by the same amount, 1.9 hours. So if you think about that, having 1.9 hours of better on time and of reduced off time, who in here would take that and think that that would be a good improvement, a meaningful improvement? I think it definitely would for a lot of people. Here's another just kind of picture to show you kind of the size of these pumps in comparison to holding it in someone's hand. So they're kind of larger, but the company makes some ways that you can carry it around your neck or in pouches, that sort of thing. But it's another consideration that you would need to figure out how to live your life with this pump. Okay, now we'll talk about our first new pump therapy that was approved in the last year. This one is Vyalev. So it was approved just last October in 2024. The medication that this pump delivers is a form of carbidopa-levodopa, but like a prodrug that's then converted to carbidopa-levodopa, and that's what acts to reduce Parkinson's symptoms. It comes as a subcutaneous infusion pump. So if you know someone who has an insulin pump, it's a very similar idea. So it's a small pump, and you just put the needle like underneath the skin. It doesn't require surgical placement of a tube. And then it delivers the medication constantly throughout the day. Looking at the phase 3 trial data that led to its approval by the FDA, we saw an improvement in off time by 1.8 hours compared to Sinemet, and an improvement in good on time per day, again, by 1.8 hours compared to Sinemet. Like I mentioned before, it's really important to think about what we might be giving up or what side effects you might have starting with these types of therapies. And the most common in these trials were definitely related to the site where the needle was inserted on the stomach. So a lot of people, like over a quarter, saw redness and some pain at that site where the needle was inserted on the stomach. And then another significant portion of people saw skin infections, some swelling where that needle was inserted, and then another common side effect was dyskinesia, so those extra involuntary movements. For this one, it's you change the needle like every 1 to 3 days, and they recommend that you kind of rotate the site where the needle is inserted to kind of hopefully help prevent some of those skin-based side effects. Okay, a few practical considerations that I think are important to mention if you're interested in this therapy or thinking about it for yourself or a loved one. Right now, since it's so new on the market, we're sort of figuring out how it's working with insurance. And based on the information that's on the company's website and that the company has told us, we're only using it in people who are 63 years of age and younger and who are not on Medicare insurances. The website says that they hope that that is going to change in the next, within the calendar year, hopefully later in 2025. But we'll just kind of have to see what happens with that. Other things that might make you a good candidate for this therapy: people have to have a good response to oral carbidopa-levodopa. That is, their symptoms respond to carbidopa-levodopa. And then the second thing that is a requirement before starting this therapy is that people have to have at least 2.5 hours of off time when they feel like their medicines aren't working per day. Here's another schematic, just kind of showing the size of the pump in comparison to a person's body. And then it shows kind of that site where the needle is inserted. There's kind of a patch, like a sticky patch, that holds the needle in place, and then this small tube that runs up and connects to the pump. And you might think, how would I go about my life living with this pump? How would I carry it around? What would I do with it? That sort of thing. So as I mentioned, the company came by and gave us a little bit of information, a little info session a few weeks ago, and they did bring a little demonstration of how people might live with it. And so I'll show you some photos of our experience with that. So here is Dr. Martinez-Nunez. He was trying on this carrying device. It comes in many sizes, but they only brought the small size that day. But because he is such an empathetic clinician, he decided that he needed to try it on and see what our patients might be experiencing. So this is me helping him apply the device. He liked it a lot. It was Dr. Martinez-Nunez approved. Until it wasn't. It got a little bit tight, and he got tired of it. So that's just kind of joking. I think that the pump goes in kind of those squares that are on the side of the vest, but they make other ways that you can carry the pump around in a way that's as least invasive as possible. Some people even put it in their pockets if their pockets are big enough. And then you can also see kind of the size of the pump there on the table and some of the things that are required to place the needle and change and prime the pump and that sort of thing. So this is a good time to also bring up the idea that coming along with a lot of these pumps, there's some ways of maintaining the pump and using the pump that require some dexterity, and that can be difficult for some people with Parkinson who might have stiff and slow movements or might have trouble with those fine dexterous movements. So in thinking about if you might be a candidate for these therapies, having a caregiver who could help with those sorts of things can be a really helpful asset if it's available to you. All right, next we'll move on to our next pump-based therapy that was again approved just in the last year. This one is called Onapgo. That's the brand name. The drug that it delivers is called apomorphine. It's one of those dopamine agonists that I mentioned in the first slides. So basically, it stimulates those dopamine receptors and acts as if there's more dopamine in the system. Although the word morphine is in the title, it's completely unrelated to morphine or any opioids. That's just the name that it has. So this one was approved just last March in February, and we're still kind of working through how this is going to go with insurance and with coverage and how exactly we're going to implement it in the clinic. So more to come on that. However, it does have a pretty good track record of use over in Europe, and it's actually been used over there since like the 1990s. So that part's reassuring that we've had some good responses in routine clinical care in a large population of people. Looking at some of the data from the phase 3 clinical trials again, they found that the amount of off time per day improved by about 1.9 hours, and the good on time per day improved by about 2 hours per day, again compared to the best oral medications that the patients were on. All right, here's another kind of schematic of the device, because I think it's helpful to be able to see what you would be working with if you're interested in this device. So it's, again, pretty small. It has the medicine cartridge attached to it and that small kind of patch thing that holds the needle in place that goes onto the stomach. And again, we'll review the side effects because I think that's important for you to have a good understanding of. Again, by far and away, the most common side effects are skin-related side effects. So things like nodules at the site, even more common than the Vyalev pump in up to 44% of people in this phase 3 clinical trial. And then there was also a lot of redness at the infusion site. Others are more related to the drug itself. So those side effects were things like nausea, increased sleepiness, more dyskinesias, and then some headaches and insomnia. And then importantly, the company just came out, or the results of a follow-up study were recently published where people continued on this therapy for 1 year. And about 70% of the people decided that they wanted to stay on the therapy. And they looked at how well people did over the course of that 1 year, and they still had that good improvement in the on time and the off time. So that suggests that the benefit is sustained at least for a year after starting the therapy. And then the last pump that we'll talk about is one that's approved, or that's being kind of considered by the FDA but hasn't been approved yet. It's called the ND0612 pump. It also is a subcutaneous infusion that delivers carbidopa-levodopa, pretty similar to the Vyalev pump that we mentioned before. It actually came to the FDA before the Vyalev pump, but then the FDA wanted some additional information, so they're working on supplying that. But looking at the phase 3 clinical trial data, again, improvements in good on time by about 1.7 hours and less off time by about 1.4 hours compared to oral Sinemet. And again, going over those side effects, they included pretty common, over half of people, some sort of infusion site reactions. Most of them were mild and not too troublesome, but they did occur pretty commonly, over 50% of people. So here's a slide that might be helpful for you if you're considering the different pumps. What's the differences between them? What's the active drug that's being delivered? Is it approved by the FDA? And then how much improvement are we looking at? So they're all pretty similar as far as improvement, somewhere between the 1.4 to 2 hours of improvement in off time, and similarly like 1.5 to 2 hours of improvement of good on time per day. Okay, for this next part of the talk, we'll talk about a few therapies that are on the horizon and ongoing clinical trials. The first one we'll talk about is called Ambroxol. It was originally used as a cough medicine, but it's being repurposed for treatment of Parkinson's disease with the thought that it might reduce levels of toxic proteins that Dr. Martinez-Nunez talked about, the alpha-synuclein, and potentially lead to disease modification, which would be a great advancement. In a recent kind of earlier phase trial, they saw improvement in movement scores, so those clinician-rated scores, by 6.8 points compared to baseline. And you might say, that doesn't mean very much to me. Is there a difference between 2 and 200? I don't know. So some researchers have kind of defined what matters to patients, what's a clinically meaningful improvement in those scores. And what they found was that an increase of about 3.25 points is what matters to people with Parkinson's disease. That sort of an increase is when people say, yeah, you know what, I do feel a little bit better than I did before. So as we talk about movement scores in the next few slides, be looking for that about 3.25 as something that matters to people with Parkinson. So we don't have any phase 3 trial data available yet because those trials are still ongoing. So there's one that's recruiting in the Netherlands right now, and then another in the UK that's planned but not enrolling yet. So more to come on this one. The next one we'll talk about is called CVN424. It's got a new mechanism of action that we're not very familiar with. It comes as a liquid that's taken once per day, and it's kind of an add-on to your other Parkinson medicines. It wouldn't be the only Parkinson medicine that you take. One of the earlier phase trials tested 141 people who took the drug for 28 days, and they saw improvements of about 1.1 hours of less off time compared to placebo, so pretty good improvement there. However, no improvement in good on times or in those movement scores. They're working on a phase 3 trial right now, and they're expecting the results of that in 2026, so more to come on this one. The next one we'll talk about is butanetep. It's got another new mechanism that prevents those formulations of, or formations of the toxic proteins alpha-synuclein. It's an oral pill that's taken once per day. Some of the earlier trials showed improvement in movement scores by 4 points, so kind of right on the cusp of what matters to people. However, an interesting and I think important finding was that it improved scores of cognition on one of the tests. So that might be an important thing to look out for, because that would be a huge benefit in people with Parkinson if it holds up in future trials. They're working on publishing the data from a phase 3 trial. It's not available yet, but they announced the top line results, and they thought it was positive, but didn't give a whole lot of additional data. So we'll wait to see kind of more details on that and on the side effects too. Next, we'll talk about a dopamine agonist that's new on the market called tavapadon. It's a little bit different mechanism of action compared to other dopamine agonists because it targets the receptors that are involved in the movement symptoms of Parkinson's, and it avoids the receptors of dopamine that can cause some of the side effects like hallucinations and impulse control problems. So that could be a really helpful thing if it holds up in trials, right? It's just taken once a day by mouth, and they've done 3 phase 3 trials, and we'll talk about the results of those on the next slide here. So they were named the TEMPO trials. Basically, the first 2 that were done were in people with early Parkinson disease, and it was the only medicine they were taking. Both of those ones showed clinically important changes, improvements in the movement-related scores by 9-10 points compared to placebo. And then the third trial was in people with more advanced Parkinson as kind of an add-on to the medicines that they're already taking. And again, that one was statistically significant and showed an improvement in on time by 1.1 hours per day. Again, we're still kind of waiting on some more details of this, including side effects. But if they're favorable, these results seem to be very encouraging to me. So as far as I could ascertain, it looks like the company is going to be going to the FDA and potentially seeking approval later this year. So I'm hopeful about this therapy and that we might have a new medication option that we're talking about this time next year. Okay, for this last section, we'll talk about a few things that you might have heard about in the news, and we'll try and go through some of the data on them. The first one we'll talk about are the GLP-1 agonists. So these have been approved for a long time for things like diabetes, type 2 diabetes, and then more recently for weight loss medications. And then just in the last year, there have been several trials that have been published that have investigated its use in people with Parkinson disease with the hypothesis that it might slow down the progression of Parkinson disease. So we'll look into the results that were published here in the next slide. Basically, the first one that was studied, called exenatide, had some promising results in a phase 2 study. However, unfortunately, a phase 3 study that was just published this year showed no difference after 96 weeks of treatment. So that was a pretty disappointing result. They also tested kind of a long-acting form of this same drug and found similarly no difference after a 36-week treatment period between the active drug and the placebo. So that was kind of disappointing results all around for the exenatide studies. For the lixisenatide, that was a positive trial. It reached statistical significance with improvement in those motor scores at 1 year of treatment. However, we've been talking about what matters to patients, that minimal clinically important difference. And this one only showed an improvement of 3.08 points on that movement scale, with the important difference being 3.25, so almost on that cusp. But side effects would be something to think about. Is that maybe clinically important difference really worth the side effects that you might get? So the side effects in this general class of medications are things like nausea, decreased appetite, and weight loss. Those would be unpleasant and uncomfortable side effects for anyone, but can be particularly problematic in people with Parkinson's disease who might already struggle with nausea due to things like gastroparesis or nausea from carbidopa-levodopa. Might be particularly problematic for people who struggle with a suppressed appetite or who struggle to keep on weight. And more weight loss can be a problem in people with Parkinson. So these side effects are really important to think about in people with Parkinson's disease before you push too hard for these sorts of medications. Okay, next we'll talk about marijuana and related products, because we'll often get a lot of questions about this. So when we think about marijuana, there's kind of two active components. One of them is called THC, tetrahydrocannabinol. That's the psychoactive part of the marijuana. And then there's CBD or cannabidiol, and that's the non-psychoactive part. Thinking back to 2020, there was this study of a synthetic THC, so the psychoactive one, called nabilone. That was a pretty good trial design, randomized, controlled, placebo and blinded, but it was just a phase 2, small number of people, only took the drug for 4 weeks. And that one showed no improvement in the movement-related symptoms, so no improvement in tremors, no improvement in dyskinesia, stiffness, slowness. But it did show that maybe it would help some of those non-motor symptoms like anxiety and sleep problems, which could be a potentially helpful thing for a lot of people with Parkinson's disease. And then just in the last year, we had another study that was published slightly different results here. So that was 61 people. They only took this drug for 2 weeks, and it was a combination of CBD and THC, so both of those active components of the marijuana, and it was in an oil form. Basically, they showed a non-significant change in those movement scores. So it was kind of a negative trial for those primary endpoints. And they did show several important side effects that we'll highlight here. So over half of the people felt dizzy, more dizzy, which can be a problem in people with Parkinson with maybe low blood pressure. They felt relaxed, which can be a good thing. They were more tired, and then they also had a lot more cognitive changes, which can again be a big problem in people with Parkinson who are already struggling with some cognitive changes without the additive effects of medications. So my takeaway from these marijuana-related trials are that, number one, we don't have any phase 3 studies. I don't think that our evidence is strong enough to make any recommendations either way about marijuana therapies, and certainly not strong enough for me to recommend them to people as a prescription. And I think that more research is needed on these therapies. We need to figure out what are the safety profiles of these compounds, what are the side effects, what are the benefits in movement and in non-movement related symptoms. What's the best way to administer these drugs? Is it by mouth? Is it by oral? Is it by smoking? Those things all need to be figured out. And then the relative composition of THC and CBD also are important things to be able to clarify as we move forward with these trials. What's keeping us from moving forward with these trials? A lot of it is federal regulation. So the DEA places very strict limits on how we can study these in scientific trials. So it can be very challenging to plan and conduct these sorts of trials in the United States. All right, so thank you for sticking with me throughout this. I appreciate your attention. We'll just kind of go over a summary of what we've talked about today. So first, we talked about one new drug on the market, and that one's called Crexont. It's a new formulation of carbidopa-levodopa, and I think it could be helpful, and people might be able to take it less frequently throughout the day. We have 2 new pumps that are on the market, Vyalev, which delivers carbidopa-levodopa, and Onapgo, which delivers a dopamine agonist called apomorphine. We've got a lot of phase 3 trials that are ongoing, so a lot of active research into the field and new therapies that I think are going to be coming on the horizon very soon. We talked about GLP-1 agonists that at one point showed some promising results, but these recent trials have been really not borne out a lot of this excitement that was initially brought up. And then finally, we talked about marijuana and related products, really concluding that we just don't have enough information to be able to recommend either way on this therapy. Okay, so coming to the end here, thank you for bearing with me through all this. I hope these studies and these updates on new developments leave you with some new hope and with some excitement about things that are coming in the field of Parkinson's disease. Thank you all for your attention, and that's all. I'd be happy to take questions later.